Peripheral vascular disease. This one's a straight shooter. You're going to have a Raynaud question. You're probably going to have a secondary Raynaud question. You're going to have a question on a phlebothrombosis or a thrombophlebitis. You're probably going to have a question about a specific venous thrombosis in that section there. Then you're probably going to have a lymphangiitis question. Let's talk about Raynaud's. It's a cold hands disease. You go out in the cold and you can't stay in the cold very long because your hands turn blue, and then you go back inside and your hands turn really bright red, and that's blood rushing back into the capillary beds of your fingers, and it can involve your nose or your ears too. And so the redness or the blood rushing back in lets us know that for there to be a reperfusion, there's got to be a loss of perfusion, right? And so that's going to present as an ischemia, and that's the blue fingers, and there's literally a cutoff of the blood flow to the involved tissue. And it's because of a vasospasm that there is a hypoxic event, ischemic event. So it's going to happen in response to cold temperature, or there can be some sort of sympathetic stress-based component. And it can be something even as minor as shopping in the frozen section at a grocery store. It's more common in people who live in the cold, more frequent during bouts of cold weather. And I think that there might be some sort of popular conception that this is a chick's disease, but no, it can happen to men too. We just don't like to admit it, you know, like put some gloves on it, right? So you go white to blue to red. That's the progression of colors in Raynaud's. First they're white, and then they're blue, and then they're red. The white is the initial vasoconstriction, the blue is the ischemia, the red is the reperfusion. So recognize this, because any question about Raynaud's is going to have this sort of characteristic progression to let you know that it is Raynaud's. And then there's primary and there's secondary Raynaud's. Primary Raynaud is idiopathic basically, and secondary is going to be due to something else. Primary is a lot simpler and a lot milder in terms of symptoms. And then secondary Raynaud, that's where it can start to eat you up and cause some distal necrosis, some extremities of the digits, some necrosis of the digits rather. So here's the symptoms for primary Raynaud's. And if you get asked a question on Raynaud phenomenon and it's idiopathic, that's the question stem right there. There's symmetric attacks. There's no necrosis. There's no secondary cause. And then nail fold capillaries are going to be normal whenever you look at them under a microscope. Primary Raynaud's is typically due to cold agglutinating IgM molecules. That's our suspicion. We don't know it for sure. And then we also think that it can be related to the autoregulation pathway within the microvasculature of your skin, and the alpha-2 adrenergic receptor is involved in that. Remember that the alpha-2 receptor is expressed on sympathetic neurons, and that your skin's got a sympathetic innervation. Your blood vessels have sympathetic innervation. And so depending on how sensitive that adrenergic innervation is to changes in cold, well, it can vasoconstrict to a vastly inappropriate amount. You know, it can constrict way too much. And so that's how we think the adrenergic receptor is involved. Secondary Raynaud is going to be asymmetric attacks, typically very, very bad attacks and bad prognoses of necrosis, ulceration, and gangrene. So the tissue can basically die because reperfusion is not established. So these are less likely to be cold associated and more likely to just kind of happen out of the middle of nowhere, although they can still be cold associated. Secondary Raynaud is always going to have an autoimmune component, an exposure component, and the exposure is going to be vibration or vasoconstriction. So again, There's the symptoms you're going to see with the secondary Raynaud question. They have to give it to you. And then what's the question going to be? Well, it's going to be which one of these factors is the Raynaud's attributable to. You'll probably make the diagnosis easily and then have to work backwards from there. So the mechanism for Raynaud's in the setting of an autoimmunity is going to be circulating components causing small vessel microvascular damage. And we've seen this already, and it's a type 3 hypersensitivity, and it's a small vessel vasculitis. And we know that rheumatoid can form immune complexes that float through the blood and aggregate in the walls of capillaries and small tissue beds, specifically in the extremities. And these are called rheumatoid nodules, right? So we've seen this before. Sjogren's syndrome associated with arthritis, autoimmunity, complexes, dermatomyositis, autoimmunity. Those immunoglobulins can get stuck to things and then deposit into walls. SLE, type 3 hypersensitivity, autoimmunity. And then sclerosis is also called scleroderma. And you tend to see multi-system organ involvement. And it's the same sclerosis that you see in Crest syndrome too, although they're slightly different. And I think it's because Crest doesn't involve the kidneys. But to sum up all of those autoimmunities, they all narrow down to a vasculitis, which is what Raynaud's is almost a vasculitis. It's technically a vasoconstriction, but you have a vasculitis that gives you a transient vasospasm, and that's the Raynaud's. Or it can be due to occupational injury. Anytime you have to, I don't know, if somebody is on a lawn crew and they're mowing the yard quite frequently, if somebody is a pilot or a machinery operator, anything causing vibrations can agitate the blood vessels in your hands and cause this sort of vasospasm characteristic of Raynaud's. And then finally, medications, and specifically here in the text, it lists beta blockers and ergot derivatives. And we've seen these two classes of medications used for one thing, both of them together, to treat headaches. And we know that they treat headaches by vasoconstricting. And so that makes sense because Raynaud's is a transient vasoconstriction. So any medication that predisposes one to a transient vasoconstriction is obviously going to exacerbate episodes. So you can sum up all the secondary Raynaud factors, 3 V's: vasculitis, vibration, vasoconstriction. And that's probably where the question is going to come from. Or this could be where the question comes from, because there's different lab values associated with both. And we know that there's anti-Joe and anti-Smith associated with dermatomyositis, polymyositis, and we've been taught that already, you know. So even if you don't remember it, I would say go brush up on it. Sjogren, it's got a HLA-B component to it. I can't remember which B. I think it might be B7. SLE, obviously, anti-nuclear antibodies will be positive. Then there's anti-centromere antibodies, which you might see in Crest syndrome, which again is a form of scleroderma. So the secondary form is more severe. There's the necrotic fingertips up at the top here. Gangrenous necrosis. So the complications are very, very bad. A couple other tools to help aid physical diagnosis. Nail fold capillaries, going to be prominent in a patient that's got some sort of autoimmunity component to it, so secondary Raynaud's. And then if you look at them under a microscope, if you see the hairpin terms here, if they really stand out, that's what you're seeing, the prominence of them. If you can see their prominent capillaries, then you are thinking microvasculature inflammation, immune complex, hypersensitivity, autoimmunity. So page 6 here is talking about the alpha-2 adrenergic receptor. Normally it's your A subunit of that alpha-2 that's on the surface of a cell, but then based on temperatures, when it gets cold, you're going to upregulate the C subunit of alpha-2 adrenergic receptor, and then that's going to predominate. So if C has a really high affinity for its ligand, well, then it's going to vasoconstrict a lot quicker than an isotype of alpha 2C that does not bind as tightly to its ligand. And so the quicker vasoconstriction, I guess you could look at it like a gain of function, that's what's going to contribute to an episode of Raynaud's, and it's an episodic disease. So it could be that, or it could again be the concept of cryoglobulins. Hepatitis C has cryoglobulins that precipitate and become more solid and more crystalline at lower temperatures, colder temperatures. And so if you have a protein in your blood that's like a rock when it's, 10 degrees outside, but then it's in its liquid phase when it's 80 degrees, well, then the closer it gets to 10 degrees, the more rocks you got in your blood. And then that's not secondary Raynaud's. Secondary Raynaud's is the microvasculature damage and things that precipitate vasoconstriction, secondary outside sources. So that's Raynaud's. Pretty simple. Talk about venous thrombosis. We got a case here. We got two cases actually. First patient has a DVT and we treat it with heparin and warfarin. And the reason why we use both is because, heparin's impractical to give to a patient to take home and administer every day. Warfarin's a nice, easy oral formulation, but warfarin has this kind of lag period before it really sets in. And so we need heparin to bridge the gap before warfarin becomes fully efficacious. And what are these two therapies working on? The clotting cascade, specifically inhibiting different factors for heparin. It's going to be factor 2, thrombin, factor 10. Then warfarin is going to inhibit factors 2, 7, 9, and 10. And we'll see why it's important to inhibit the clotting cascade to prophylax against a venous thrombosis, as opposed to inhibiting platelets whenever we're worried about an arterial thrombosis. And those two therapies commonly go together, depending on the pathology. One more case here. This is going to be a thrombophlebitis, and it's infectious in nature. And we're going to treat it with metronidazole because this patient's got lung abscesses, and those are very often polymicrobial, so you need a broad spectrum with anaerobic coverage. And then there's also bacteria within this patient's veins, the internal jugular, as a complication of tonsillitis. It's kind of a contiguous spread of bacteria through tissue into the wall of a vein, which we know is pretty flimsy, does not have good defenses. So metronidazole is the antibiotic that's the broadest spectrum and allows us to use only one antibiotic for this. So let's talk about phlebothrombosis and thrombophlebitis. Both of these are venous thromboses. That means it's a clot that originates in a vein, right? It doesn't originate in an artery. That would be an arterial thrombosis. And it's really important for you to know that an arterial clot and a venous clot are not the same thing. If you chop them apart and looked at them, they would have different forms. They would be made of different things, literally. And an arterial clot is comprised largely of platelets with some fibrin in there. But a venous clot is not going to have very many platelets at all. It's going to be mostly fibrin and red blood cells. And so this affects our therapies because you can't treat a clot that's 90% platelets without using a platelet inhibitor, because it doesn't matter how much fibrinolytic you throw at it. because the platelets are all making ADP and thromboxane A2, right? And so they're magnetizing each other, and they're just attracting one another. And this clot in an arterial vessel is made of platelets, and so you have to give something like aspirin, which is going to cut off prostaglandins at the source. And you have to give something like clopidogrel, which is going to stop platelets binding to one another because it interferes with the ADP release by platelets, right? So that's our thinking for treating an arterial clot. And that's why you got to give aspirin to someone who you're suspecting a coronary artery thrombus in. That's why we give aspirin there. Versus a patient who's at high suspicion for a venous clot. Now, what's the prototypical patient for this? Bed rest following surgery, because we know that stasis is one of three components of Virchow's triad, and stasis encourages venous clotting, specifically venous clotting. So because venous clots are a whole bunch of fibrin, not a lot of platelets. You don't need platelets for a venous clot. It's not that they're not there. It's that you just don't need them to get the clot going, because the flow of blood is slower in veins. And so the coagulation cascade, which activates fibrin, can activate itself without needing the help of any wall damage or platelets to get it rolling. And so the coagulation cascade is going to start with 7 or 9, and then they're going to meet at 10, and then that's going to walk all the way down to 2, and that's thrombin, right? And so thrombin gets activated, and then thrombin turns fibrinogen into fibrin. And this happens so much easier in the venous circulation because it's slower. So the red blood cells come in because, well, you've got this big web of fibrin, and it's kind of like solid metal silly string all over the place, right? And a red blood cell sees it and it just sticks right on it, and it stays there, and nothing is getting this red blood cell off that sticky fibrin. So again, the platelets, can you have platelets in a venous clot? Yeah, absolutely. But the point is, you can't treat a venous clot with a platelet inhibitor because there's so much fibrin. You need a fibrinolytic for a venous clot. And that's at the center of a really big drug decision, which is, this patient's got a clot, obviously. What do I give them? And that was even a question on our ClinMed test today. And it was like TPA was one answer, and then like clopidogrel was another answer. And man, you got to understand that arterial clot, venous clot, not the same thing. Okay, so moving out of that and moving back into this text, we're talking about venous clotting. And there's two types here, and the difference between a phlebothrombosis and a thrombophlebitis is going to be the initial injurious event that gets the clot rolling, right? So wall injury is not very common in the venous system. Wall injury is really common in the arterial system, right? Because there's high shear force, there's turbulent flow, you know, and this blood is coming straight out the heart, and it's ready to go. It's ready to move, and so it does move, and it moves against the artery. And so those endothelial cells in your artery, they got to be able to take some hits, right? Because that blood is hitting it. And we know that platelets stick to endothelial damage, and so that's part of why arterial clots are platelet based, is because there's almost always endothelial damage involved. And then the blood is moving so fast in your arterial system that your clotting cascade needs that endothelial damage to give it a place to start. So endothelial damage, not common in the venous system. Why? Blood is slower. Good explanation for it. But it can still occur. And when it does occur, that's going to be called a thrombophlebitis. Now, a phlebothrombosis is a clot in the veins that does not start because of wall damage. It starts because of hypercoagulability or stasis. So thrombophlebitis, moving back to that, it's a venous clot caused by wall damage. What could damage the walls of your veins, right? Because we just said that the flow is so slow and nothing's going to damage those walls, you know, but an infection can do it. And in fact, thrombophlebitis, notice the itis at the end for inflammation. Thrombophlebitis is almost exclusively set into motion by a vessel wall infection. Okay, so that makes sense, right? You damage the wall, makes it a whole lot easier for a clot to form. Now, a phlebothrombosis has no wall damage, but it just so happens that blood in your veins moves slowly enough to promote the formation of a free clot in the right circumstances. So this is a circumstantial clot. That's how you got to look at it. And the circumstances can be stasis, patients not moving, because we know that muscle helps to pump blood up through veins, and then you've got valves in your veins. And so if your muscle's not pumping, well, then the pressure in those veins is not, it's going to take a long time for it to build up enough to move it through a valve. And then another circumstance that can engender phlebothrombosis is hypercoagulability. And this can be due to a inherited coagulopathy. This can also be due to a polycythemia. You've got too many cells in your blood. It's too viscous, so it's moving slower, right? So that's the chain of events that will start a phlebothrombosis, which does not have wall damage at the beginning of it. Before we move on, I want to give a shout out to Virchow's triad, because this is so important, and once you understand it, it makes clinical decision making a lot easier, because you don't have to remember what to do. You have to remember the triad and then maneuver around it. So it's basically 3 categories to remember, 3 categories of ideas, and each concept is going to be a pillar of clotting. So there's wall injury, talked about that. There's stasis, blood that sits still is easier to start the clotting cascade, easier for those proteins to interact with one another when everything's just chilling. And then changes in the composition of the blood, or hypercoagulability, and this is commonly associated with cancer, and this is commonly associated with pregnancy, high estrogen for whatever reason, and then again, hereditary coagulopathies. So get used to thinking in terms of that triad. Phlebothrombosis. Now that we've already talked about it once, let's try to roll through it. Big risk factors of pulmonary thromboembolism. And it does not involve an infection. And it's caused by an abundance of clotting factors or a stasis of flow. So the prototypical patient is hospitalized, sitting in a bed. And phlebothrombosis most commonly occurs in the iliofemoral large veins of the leg. Now, thrombophlebitis, itis for inflammation. Because there's an infection, you get the inflammation alongside the wall damage, and the wall damage is going to allow a clot to form right there on the wall. So this thrombophlebitis is associated with a lower risk of pulmonary embolism because, well, the clot's on a wall rather than being a free clot without endothelial damage. in the case of a thrombophlebitis, the endothelium is compromised, and so the clot starts to stick into the wall. So it's way harder for the slow venous blood to jar that clot off of the wall, right? And plus you've got all these neutrophils and immune cells and bacteria, and they're providing a sticky glue-like substance for the clot to further embed itself into the wall. So the thrombophlebitis has a much lower risk of embolizing than the phlebothrombosis. So it, in some cases, is not an infection. It can be due to wall damage caused by an intravenous catheterization or an injection. Anytime you need to place an IV line, you run the risk of there becoming a venous infection at the site where you place the line, and then the infection can turn into a clot, and that's not very nice. That's the sort of thrombophlebitis that would probably embolize. Symptoms for thrombophlebitis are going to be different than phlebothrombosis. Thrombophlebitis usually going to be fever and chills secondary to the infection. And then the limb's going to swell up really, really bad because of the infection. It's typically an infection. And then it's going to be tender. Why is it going to be tender? Because of the infection. So I think that previous page is probably a question in some capacity. I think that the next couple of pages too is also a question, just because this section's titled Special Types of Venous Thrombosis, but it lists 7 of them, you know, so it's like the odds of one of them being asked about is fairly common. The big ones I think are going to be Trousseau syndrome and Budd-Chiari syndrome, the 2 named ones. Anytime something's got a proper noun to it, you know, it's count on it. And then a DVT, obviously. Man, I barely highlighted anything here because all y'all know how DVT works by now. It's going to be the big veins of the legs, femoral vein, popliteal vein. It's got to be a deep vein, not a superficial vein. Big risk is pulmonary thromboembolism, so we use heparin and warfarin prophylaxis. Again, why do we use heparin and warfarin to prophylax against venous clots? Because venous clots are dependent upon the clotting cascade, because it's a lot of fibrin in a venous clot relative to platelets. Risk factors: immobilization, obesity, smoking, sitting on an airplane. Anytime you got to sit still for a long time, real talk, I know it sounds unlikely, but it's happened to people. Just sitting down for 6 or 8 hours. So maybe something like taking your med school boards. No, I'm just kidding. Oral contraceptives, strong correlation, don't know the mechanism. Pregnancy, same thing. We know it's estrogen-based. Surgery and trauma, again, anything that's inciting an injury into the vein, and then surgery because you'd be immobilized. That stasis is a component of the Virchow's triad. And then medical conditions, antiphospholipid syndrome and cancer, those are promoting coagulation. Those are promoting a hypercoagulable state. Inherited things: factor V Leiden mutation, prothrombin mutations. Good to know about. We'll hit those in block 7, not now. Superficial venous thrombosis, know that it involves varicose veins. I've actually seen that in a test question. It's like, oh, this person's got a thrombosis, and it points at the vein, but then you got to know, oh, that vein's right under the skin. And so the answer was like no further risk, you know. Migratory thrombophlebitis. This is Trousseau syndrome. What you need to take away from Trousseau syndrome is that if you see this patient have venous clotting that starts moving in its distribution, maybe it's here, and then maybe it's here, you know, maybe it's in their knee, and then maybe it goes to their hip, and then maybe it goes to their other hip, right? That's when you're like, oh, cancer. I should be thinking cancer. I should be thinking malignancy. That's Trousseau syndrome. Superior vena cava syndrome is going to be a clot in your vena cava. So it's got to be a pretty big clot, you know that. But it can also arise due to compression of the vena cava. which is going to create backup and subsequently stasis upstream of the compressed element of that large vein. Superior vena cava can be compressed by a tumor. This is most commonly what happens. Most common cancer, most common tumor is going to be a lung cancer, a small cell carcinoma. And what are the symptoms going to be? Well, if you put a clamp on the superior vena cava, I'm sorry to be right here. If you put a clamp on the SVC, what do you think would happen? They'd get all the symptoms of venous backup, so like pitting edema, prominent jugular vein, except it'd all be above the chest because it's only the superior vena cava. And so then the same concept when applied to the inferior vena cava gives you inferior vena cava syndrome, and you're going to see things like hepatomegaly, you're going to see pitting edema in the lower extremities. And then the compression of the IVC in inferior vena cava syndrome is also most commonly due to cancers. And there's different cancers for the IVC compared to the SVC. I think that is a possible angle for questioning. I don't think it would be high yield to know that. Here's the specific cancers in the middle of the page on page 10. Retroperitoneal leiomyosarcoma, so a malignant smooth muscle cancer. Adrenal cortical carcinoma, that one can spread pretty rapidly. And renal angiomyolipoma, so that one's got a little bit of everything up in it. And all of these have exhibited the ability to expand enough so as to compress the inferior vena cava, and then everything upstream of the point of compression is going to have slower blood flow, so that's going to help kick off a venous clot. And anytime we find a tumor associated with these patients need spot radiation as soon as possible. And if we can cut it out, you need to cut it out. Budd-Chiari syndrome, hepatic vein thrombosis. All right. So the hepatic vein, the liver's got two veins. And so I know that might confuse some people. So let's lay it out. I'll draw it too as I'm saying it. You got your nice triangle-shaped liver, and then you got one vein going in and one vein going out. And the vein going in is your portal vein. And then the vein going out is your hepatic vein. So that's the anatomy of the two veins of your liver. So either of these can get squeezed. Stasis follows, venous clot follows, right? And then either of these can also get a big old clot within them. So a clot within the hepatic vein, it's called Budd-Chiari syndrome, and it's going to cause nutmeg liver. And so I did proclaim in my heart failure video, I said something like, oh, I don't know anything else that's going to give you a nutmeg liver. And that's because poor uneducated me had not yet read SDL-13, Peripheral Vascular Disease and Venous Disorders. So if you have watched that video on heart failure, please forgive my simplicity and lack of understanding, and know that Budd-Chiari syndrome is one thing besides right heart failure that can give you a nutmeg liver. So what's the nutmegging of the liver? Centrilobular hemorrhage. And let's go a little bit more into the liver today. I'm digging some liver anatomy. So your liver is set up to where it's got these hexagonal lobules. Man, those are two words I've never used back to back. And you've got different zones within your lobules, right? So your liver's got lobules, and you've got zones within your lobules, and then there's different types of cells in each zone. And specifically, you've got a zone 1 and a zone 2 and a zone 3. So the way that the liver works is that the blue dot that's the bullseye in the middle of this drawing here, that is your central venule of one lobule of your entire liver. And your liver is just made up of nothing but lobules like this. It really does not have functional tissue outside of these honeycombed hexagonal lobules. And blood moves from the outside into the middle of the lobules. So there are also going to be veins located around the periphery of these lobules. And those are going to be the portal veins coming in from the gut. And so then your hepatic venule basically is made of all the blood that comes out of all these central venules. So in the middle of each lobule is blood going out of the liver. And then around the outside, around the perimeter of each lobule is blood going into the liver. So a hepatic vein thrombosis is going to back up the centrilobular venules because that's blood going out of the liver. So if blood can't get out of the liver, where do you get the venous backup? And the answer is right here. X marks the spot in the middle of the lobule. So that's the concept of centrilobular damage. That's your nutmeg liver, right? And that is the same nutmeg liver that you get with a right heart failure, and it's venous backup. So you volume overload from the heart to the liver. And so because the vein in the middle of the lobule is the one that gets the blood from, or it's the output vein. If there's a backup, that's the first vein to be hit in heart failure as well. So that's why it's a spotty nutmeg liver appearance. Most commonly, the thrombosis of hepatic veins is due to changes in the composition of the blood or hypercoagulable states. One example of this is polycythemia vera. You just have too many cells in your blood. It's viscous and slow. Myeloproliferative diseases, same concept. Where's blood cells made? Bone marrow. Myeloproliferative, bone marrow multiplying. Okay. Paroxysmal nocturnal hemoglobinuria. This one's cool. This is a lack of decay accelerating factor, also known as DAF, D-A-F. And what DAF does is it stops. It puts a stop on the complement cascade. So you know you always have complement floating around your blood. You got C1, C2, C3, C4, C5, right? And so they're cut from their 5 form to their 5A and B and C form, right? Because the complement cascade is a proteolytic cascade, very analogous to the clotting cascade. So what's the complement cascade do? Well, it pokes holes in things indiscriminately. That's all that it does, is poke tiny little holes in every cell that it sees. And so your body has a stop protein, right, to stop the complement cascade, because it doesn't want holes being poked in everything. But it just so happens that being indiscriminate about it is a very biologically adapt defense mechanism, because it doesn't require you to know what your enemy is. It just pokes holes in everything, and then you tag your friends with friendly and you stop the cascade that way. But every possible enemy out there from a microbiological level can get a hole poked in it by complement. So that's the pro of complement. The con is that if you can't turn it off, it'll start poking holes in your own cells. And so paroxysmal nocturnal hemoglobinuria is the name for the condition given to the phenomenon of red blood cells being poked open by complement, because you're missing the protein that goes, whoa, 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 stop, whenever complement starts to poke holes in red blood cells. And then oral contraceptives, we said estrogen promotes coagulability, same thing there. Talked about the nutmeg liver. So that's Budd-Chiari. Portal vein thrombosis. Okay, so a portal vein thrombosis is going to cause a backup into the bowel, because here's our portal vein, right? Here's our portal vein. And so it's going into the liver. And so where does the liver receive venous blood from? And the answer to that is the gut, because the liver gets first pass metabolic crack at everything absorbed from your intestinal lumen. How does it get to the liver from your gut? The portal vein. So if there's a blockage in the portal vein, where's the backup? In the intestines. So this can lead to ischemia of the bowel, hemorrhagic infarction of the bowel. Why? Volume overload. And those tiny little arteries just pop because they've got so much blood in them and it can't get past a clot. So this is potentially fatal, because if you start bleeding into your peritoneum, there's a couple of other organs in that cavity besides just your bowels. And so the hemorrhage is going to create a mass effect, right, and start to crowd out and induce ischemia, compressive ischemia in organs such as your liver and spleen and your kidneys and your large and small guts. So that's the mechanism there. And you're going to see characteristic symptoms, two of them, esophageal varices and splenomegaly. And you could possibly see an elevated D dimer. And just to get you ready for the lungs, the D dimer is also going to be our gold standard test for a pulmonary embolism. So we are out of venous territory. Let's talk about lymph for a hot minute, and then we'll wrap it up on this one. So lymphangiitis, two types, linear and nodular, okay? So look at these pictures. Right here on the left, you've got your kind of linear, traditional lymphangiitis, and then over here, you got the counterculture. It's in nodules, man. So what is a lymphangiitis? You get a hole poked in your skin, some bacteria gets in, the bacteria goes into your lymph nodes, and it just crawls up the thing like it's a ladder, and you need to catch it quickly before it just causes the patient an inordinate amount of suffering. So lots of different species can cause this. Pasteurella is common because it occurs after a dog, cat bite, animal bite, and remember, you get lymphangiitis whenever the skin's punctured. So a bite would do that. And the go-to factor about Pasteurella is that it's got a big capsule on it, and it grows on 5% sheep's blood, and it's oxidase positive, and you can see it with an osteomyelitis. A couple of other bugs that can cause lymphangiitis can be Sporothrix schincki and Nocardia, and you can both get those from soil, and Sporothrix specifically is associated with rose bushes, gardener's thumb, it's traditionally called. Mycobacterium marinum, never heard of that, but I'm assuming it has mycolic acid in its cell membrane. Leishmania, we've seen Leishmania. We know it's transmitted by the sandfly. Wuchereria bancrofti, we know that's transmitted by mosquitoes. So a lot of different sources, all of them involve puncturing the skin. Now, a linear lymphangiitis. This paragraph above the pictures is exactly what the test question is going to give you with any patient with this sort of lymphangiitis, picture or not. And then with the nodular lymphangiitis, same thing, but it's basically going to be isolated bumps proceeding from the site of cutaneous infection towards regional lymph nodes. And so then nodular lymphangiitis particularly is caused by Sporothrix, which is a fungus. And everything that you need to know about it is right there. And that seems to be it for peripheral vascular disease and venous disorders. Thank you very much for your time.